Try this.
Yep. Okay, everybody. This is the last PowerPoint for joints. So, there are different kinds of synovial joints. Talked about this a little before. The last the last PowerPoint was giving a general overview of types of joints. In this one, we're going to talk about specific joints. So, they all have the same general features. We already talked about the fact that you have, in the synovial joint, you have articular cartilages made out of hyaline cartilage. You have a joint capsule made out of connective tissue. You have, the outside layer made out of connective tissue, inside layer being a synovial membrane that's synovial fluid that lubricates the joint. So let's go through the five big ones. Five main synovial joints. The temporomandibular, right here, the temporal bone is the skull and your mandible. That's for our jaw. Our shoulder joint, which of course is a ball and socket. What the hip is, the hip would be a bigger ball and socket, so it has less motion, but deeper acetabulum, the socket. The elbow, which obviously we're talking about the ulna articulate, the humerus, right? And the knee. So, and especially the knee, that's a big one for athletes. So, all right, so the jaw is a hinge joint. By the way, the jaw is a modified hinge. The elbow is also a hinge joint. Anyway, the mandibular condyle. Now I'm going to ask a question here. Since we're talking about this specific part of the mandible, and it was one of those things that you couldn't memorize before on the mandible, and now we're seeing it again when we're not talking about bones, when we're talking about joints. If it shows up more than once, do you think it might be a more important thing? Yeah. Okay. Anyway, the posterior temporal bone has an articular surface called the mandibular fossa. Remember, just like the scapulohumeral fossa. Yes, yes.
Is this the A on the
AB. Yep. Okay. And the anterior portion has an articular tube. The articular capsule on this joint forms a strong lateral ligament. That's to help keep the jaw from dislocating, help keep it in place. All right, so we have two types of movements in the jaw that it can do. The hinge movement would be jaw goes down, jaw comes up, jaw goes down, jaw comes up. Okay? Gliding would be side to side. If you ever think of when you see a cow chewing its food and its mouth kind of goes around like that, that's the gliding motion. What's happening is here are the two parts. You can have this movement going on with the bone, again with the mandible against the temporal bone. Does that make sense? This joint, that movement is what causes the hinge. The jaw is the most easily dislocated joint in the body. So, here we have it. And the articular capsule, which is the synovial joint. And here we have the lateral ligament that we were just talking about. The lateral ligament helps reduce the amount of dislocation, keep you from going too far to the side. All right. So lateral ligament has two forms of motion. If we look at it right here, close up of that joint under the lateral ligament inside the capsule. Here we have the capsule, okay? We have synovial membranes making synovial fluid. It lubricates this area where you have the two articular surfaces made out of hyaline cartilage rubbing on each other. Okay? This upper articular capsule that's on the temporal bone, this lower one, is on the condyle. Yes?
This week's PowerPoint. This week's PowerPoint.
Okay, hold on, let me put it up. Okay, it's trying to upload right now. Let's move on. Okay. So this shows the two types of motion we were talking about before, or the type of motion we were talking about before, the sliding. You can move your jaw side to side while moving your feet. Is everybody good with that? Sure. TMJ. Here talking about TMJ. That's temporal mandibular joint. Dislocation of it is common because of the shallow socket. And if it dislocates, it probably dislocates by having the jaw, the mandible, come forward, and you can't close your mouth. Realign, a doctor is going to have to shove your jaw back in. No problem, not. Let's go back here. Yep. Floating. So symptoms of TMJ dislocation. You're in face pain, your muscles hurt. When you open and close your mouth, you have joint stiffness, popping sounds. It can be caused by grinding your teeth, but it could also be jaw trauma, being an accident hitting your jaw, or poor occlusion of teeth. Your teeth don't come together in the right way. Treatment for grinding teeth might include giving someone a bite blade to bite on instead of grinding the teeth, or trying to relax the jaw. Now, how are we doing? We're closer. All right. Okay, glenohumeral. You remember the socket in the shoulder is the glenoid fossa of the scapula. And the ball that goes in is the head of the humerus. So when it says the glenohumeral joint, they're talking about scapula and the top of the humerus, the proximal humerus. It says this is the most freely moving joint in the body. If you think about it, we need to use our arms a lot. So we have this very, very movable joint, but it's not super stable. Let's just do something. You guys, can you hold hands? All right. So The ball and socket, like I said, you have the head of the humerus fitting in the glenoid cavity of the scapula. Good analogy here. A golf ball sitting on a golf tee. There is a little surface there that's cupped out for the ball to sit in, but it doesn't really restrain or hold it in place. Still working. And there is an articular capsule, a synovial capsule. It's thin, it's loose, that allows a lot of movement. If you look right here, you have the acromion above. Remember I really should have got the skeleton out. We have a bursa between the two. Okay? There's a tendon sheath, and above that a bursa. In other words, if you're moving this around, you have cushioning, you have padding to protect the tendon of the biceps and to protect the head of the humerus from smashing against the acromion process. Project. Would you guys be willing to go outside? Okay, just do it quieter then, because I can hear you all, and it's distracting. All right, thank you. Anyway, so the synovial cavity here, again, you have all your normal stuff. You have the synovial membrane that makes the synovial fluid. You have a stopper connected to the outside. On this, I definitely want you to know there's a tendon sheath on the biceps brachii. The reason I want you to know that is that's the example before when we first talked about bursa and tendon sheath. So, again, it's something that you see more than once. All right, here they have. No sound. It just rotates so you can see it falling. Looks by itself, it's not bad. Right, let's make sure we're actually definitely. So, picture of what we just talked about. Laura talked about the details. The humerus, head of the humerus, articulates with the glenoid fossa on the scapula. The acromion remember that's the fat wide part at the end of the spine on the back of the scapula. That's above the whole thing. You got the tendon coming through here with the biceps and bursa right there to cushion. All right. Now remind me that you're present for marked absent.
My bad.
All right. So let's talk about the labrum.
Thought you had already told me. Okay.
All right. So around the edge of the glenoid fossa, glenoid cavity, you have fibrocartilage, and basically it's like the bone was really shallow. Remember how we compared it to the hip where the acetabulum bigger socket? You got some fibrocartilage that wraps around. It's like an add-on to the bone to give it a little more depth, help keep the humerus in place. Anyway, the cavity still only holds 1/3 of the head of the humerus. That's why the humerus dislocates. On the anterior, on the front, we have a coracohumeral ligament that goes from the coracoid process on the scapula to proximal end of the humerus. It helps support the weight of the upper limb. Fancy way of saying it keeps say you're lifting things with your arm. It helps prevent it from falling out of the socket coming down. All right. And the glenohumeral ligaments, they strengthen the interior, but they're not that strong. That prevents the arm from being pushed forward out of the socket. Here we have those 3 ligaments. All right, so you've got one ligament for the jaw that you need to know for this PowerPoint. You've got 3 ligaments here for the shoulder. Everybody good with that? Yep. All right, and this is what we talked about. Let's see how we're doing on the other. Oh, close. Here, close. All right, so capsule, you remember, tough connective tissue surrounds the whole thing. All right. It's made out of the same connective tissue. You can see the ligaments coming out, but they're part of the wall of the capsule right there. So, humeral ligaments, tendon of the long head of the biceps. You have folds in here that the tendons come through. All right. These reinforcing muscle tendons that we have, we're talking about the subscapularis. That's located below the scapula, between the scapula and the ribs. Good. That's what the name tells you. The supraspinatus, that's the upper part of the scapula. So this is the scapula, there's the spine of the scapula going up from you right here. The area above that spine, that's your supraspinatus. The area below that spine of the scapula, that's the infraspinatus. So these 4 muscles are the rotator cuff. If you hear someone say, oh, they tore their rotator cuff, these tendons go around the capsule and help hold it in place, help stabilize it, try to keep the shoulder in place. But they already said it has this high range of motion, easily dislocated. So if I was to ask you these muscles, what's their purpose? It's going to be to help hold the shoulder in place, help hold proximal end where it's in the saucer. Everyone good with that? All right. So there's a second. There is a dissected joint capsule you can see in it. Rotator cuff muscles right here. The acromion process of the spine and the scapula, the glenoid fossa right there. The labrum, remember, is the extra fiber cartilage that wraps around. It's like adding a lip to the glenoid cavity to make it come around a little bit more. And that obviously is the head of the humerus, articular cartilage here, articular cartilage there. This is a posterior view, so we're looking from the back, which makes sense if you're acromion here. Everyone good with that? Yep. All right. Shoulder dislocations are a common problem because the shoulder is very mobile. These joints are weak to the front, back, and the head of the humerus can easily, so front and downward. So the head of the humerus can easily dislocate that way, either to the front or down. Glenoid doesn't provide a lot of good support if you're laterally, if you're rotating the humerus laterally, or if you're pulling it away from the body. Yeah, it doesn't say that, it's only right here. So that, the head doesn't stay perfectly in the socket, it pulls part away and pulls the gap, kind of like we had in the last picture. And it's easier to fall out of the socket. Close to the top or the back of the shoulder. All right. Let's do a little video on rotator cuff. That sound.
Rotator cuff is a term Rotator cuff is a term used to describe the group of muscles and tendons that stabilize and reinforce the glenohumeral joint and assist with the angular and rotational movement.
Seriously? That's the video? I think we got that.
All four muscles combine by way of tendons that form a cuff over the joint, hence the name rotator cuff.
Okay. That is our amazing video. Check on close. Oh, perfect.
The anterior scapular muscles that cross the glenohumeral joints are the coracobrachialis, the biceps brachii, and the delta. The coracobrachialis muscle originates on the coracoid process of the scapula and inserts on the medial surface of the humeral shaft. Biceps brachii muscle has two parts, a long head and a short head. The short head originates on the coracoid process of the scapula, while the long head originates on the supraglenoid tubercle glenoid cavity. Two heads of the biceps come together distally and insert on the radial tuberosity, just distal to the elbow joint.
I want you to notice what that means.
The deltoid muscle is composed of three distinct sets of fibers: the anterior fibers, which originate from the anterior border and lateral third of the clavicle; the middle fibers, which originate on the lateral margin and acromion of the scapula; and the posterior fibers, which originate on the posterior border of the spine of the scapula. All fibers converge to insert at the deltoid tuberosity of the humerus.
Okay, looks like it's not now all done. What I was going to say is the biceps is crossing two joints. Got that? Not one. It crosses because it's attached to the girdle, goes over the shoulder and over the elbow as well. Everybody good with that?
Sir.
All right. Yeah.
The posterior scapular muscle that crosses the glenohumeral joint is the teres major muscle. The teres major muscle originates on the inferior angle of the scapula and inserts on the medial edge of the intertubercular sulcus of the humerus.
Now, that was the shoulder, most highly mobile joint we have. Now we're going to talk about the elbow. Elbow's a hinge joint, and talking the trochlear notch, the trochlea of the humerus, the trochlear notch of the ulna. Everybody good with that? All right. Flex and extend. That's all this joint does. The rotating that you have is not involving the elbow. It's just distal to the elbow where the radius is articulating to the ulna. Everyone good with that? All right. There is a ligament that holds that head of the radius in place. It's called the annular ligament. The two tarsal ligaments that restrict side-to-side movements, stop the elbow from moving this way or this way, are the ulnar collateral ligament or the radial collateral ligament. Go into them. Yeah.
The forearm flexors consist of the brachialis, brachioradialis, and the biceps brachii. Brachialis muscle originates on the front distal half of the calyx and inserts on the coronoid process of the ovum. The brachioradialis originates on the lateral supracondylar ridge of the humerus and inserts on the base of the styloid process of the radius. The biceps brachii has two parts, a long head and a short head. The short head originates on the coracoid process of the scapula, while the long head originates on the supraglenoid tubercle of the scapula. Two heads of the biceps come together distally to insert on the radial tuberosity, just distal to the elbow joint.
What was? Go ahead. What?
What is this one?
Distal is away from the midline of the body. Proximal is close to it.
Okay.
So distal is further away. All right, so here we have a schematic, a kind of a drawing of the elbow. And you can see that we have the humerus coming down, and we have the trochlea of the humerus right here. We have the trochlear notch in the ulna right there. They're not listing it, but this is your funny bone. This is your olecranon process. Everybody good with that? All right. We have tendon of the triceps coming down. Remember, your triceps is your extensor for your elbow. So if your elbow is going to extend, it extends because the triceps muscle gets shorter and thicker. So as it gets shorter, it pulls and pivots. Good? Pretty clear? Now, just like the others, this is the third synovial joint of the main synovial joints that we're going over. The first one was Erica. First one was, there were 5 main synovial joints. The first one was the jaw, which temporomandibular joint. Second one was shoulder. The third one doing right now is elbow. Going over all 5. All right. So tendon of the brachialis down here. This be the origin or the insertion of this muscle. That'd be an insertion. The origin is where we start. The origin generally is more proximal. That's the insertion. And the brachialis inserts on the coronoid process. All right, moving on. So here we have a drawing of the same thing, but we have the muscles pulled away. Just see the bone and the connective tissue. The lateral epicondyle is, we have this collateral ligament, radial collateral ligament. It holds, but it's part of what's holding the radius in place, in against that articular notch, the radial notch of the ulna. But it also holds the joint, the elbow dislocating side. Does that make sense? Everybody see that? Okay. So lateral condyle down to right here on the electron. This will electron process. All right. There is a picture of the same thing instead of a sketch. This time they sected out real one. Ulnar collateral ligament, annular ligament. I don't see the video. Probably could run the side here. Yeah, radial. Okay, so those 3, the annular, the radial, and the ulnar are the ones that you'll want to be able to identify from this joint. Good? Let's take a look. See, okay, that is uploaded. Let's now save the thing. Okay, Jaslyn, can you see it now? I'm going to move on to the next slide. Okay, going to show how the elbow rotates. Okay, excellent. We're going to show how it rotates. But what you'll see is the rotation is turning the radius in this radial notch. Oh, it's not showing that. I misunderstood when it said rotate. Oh, look at it from all sides. Yeah, got that. All right.
The elbow joint is a hinge joint. Therefore, the muscles that act on this joint are limited to flexion and extension of the forearm at the humero-ulnar joint, while the forearm itself is capable of pronation and supination.
All right. So now we're going to talk about the hip. Huge ball and socket. Deep socket on the acetabulum. So, large spherical head of the femur, that's on the proximal end. We call it the head. Mirrored area right past the neck. And it's in that ball goes into a deep socket that we call the acetabulum. Remember, that's where the ischium, the ilium, and the pubis come together. They'll come together with the acetabulum. And the acetabulum has a labrum, just like we had for a lift. Labrum, like labia, like lip. Okay? The lip around the edge of that socket. Again, it's tough fibrocartilage. Just like we were doing on the shoulder at the glenoid, but we're doing it even more. Again, it increases the depth of the socket, helps to keep the bone in place. Okay? Has good range of motion, but not as good as the elbow. If I was to ask you which joint had more range of motion, the elbow has more motion because it has less of a cup to hold it. All right. When I say elbow, shoulder has more range of motion because of the cup. All right. So here we have the cutaway drawing. We have the ligament of the femur, okay, from the head of the femur going here to our ischium, right? The acetabular labrum, this is extra fibrocartilage. And now, yeah, this is straightforward. We're going to move on. Obviously, there's synthesis.
Two principal anterior muscles of the hip, the iliacus and the psoas major. Collectively, they are known as the iliopsoas muscle because they share a common insertion, lesser trochanter of the femur. The iliacus muscle originates on the iliac crest and fossa of the pelvis. The psoas major muscle originates on the bodies of vertebrae T12 through L5 and the transverse processes of all of our vertebrae.
So there's labrum, fibrocartilage, around it. Right here where it says And then here we cut the capsule. Yeah. Yep, the ligament of tears they were talking about right here. It's shown right there. Do you remember when you were looking deeper and on the head, on the ball, there was a little scooped out area? That's called the fovea capitis. That's the ligament capsule. There. All right, moving on. So we have ligaments around to help hold it in place. We're about to go over them, but the iliofemoral ligament, obviously, is from the ilium to the pubofemoral from the pubis to the femur, ischiofemoral from the ischium. Then the ligament of teres, we already said that's got little one, short one that goes from the little concave spot on the head. This ligament of teres, most of the time it's slack and it doesn't help stabilize. Does have arteries that contain blood flow to feed the articular surfaces of. All right. There we have it. They say that it has great stability because the ball and socket, the acetabulum with the labrum around it. So if we look right here, we have the greater trochanter, lesser trochanter, iliofemoral ligament, ischiofemoral is down. It has multiple heads, multiple attachment point spots. And as you can see from the back, you would have known that anywhere from this. And from the back, this is the same thing from the front. Okay, we have the iliac spine on the front side. The iliofemoral ligament coming front of it has heads on the side. Pubofemoral comes so got two parts of this, one on the front, back, parts. So you have three strong, regular, dense, regular bands on the front and on the back, trying to hold this side. And the ligamentum teres, which actually it's slack most of the time, but it's running from the head, from the fovea capitis on the head, into the hip bone, coxal. That's just brown. See it? Okay, I see what they did. I was like, huh. If you look on the medial surface side, stop. I was like, what on earth is going on? It's that they cut the bone away so you can see the head. All right. So those are the parts that we need to know for. Yep. Let's talk about the knee. the most complex joint you have. Think about supporting all the weight, and you have to be able to rotate the foot. You have to be able to invert the foot. You have to be able to swing it forward and backward. All right, the patella, giant sesamoid bone, is, remember, a tendon protector. It's a plane joint, and it glides forward and back in that groove on the end of the femur to protect the tendon from it. Okay. The lateral and medial joints together are the tibio-femoral joint. Okay. So you actually have two articular surfaces. Between the condyles and lateral meniscus. Okay, plural would be menisci, but you have a meniscus. Those are made out by the cartilage, and fat pad. The hinge joint lets you flex, extend, and you have some rotation, partially flex. All right, let's move on. Here it is. Notice we have the tendon of the quadriceps coming down and the patella embedded in it. Articular cartilage on the patella, articular cartilage on the bottom of the femur. Here we have a bursa. We have a little water bed, a little cushion that the patella is rubbing against. Okay? Or the patella is rubbing against. And here we have a little bit of a cushion on the front. We're wanting to make it things subdued. Okay? These bursa, these cushions, they are filled with synovial. Now, the meniscus or the fat pad, we have one on the lateral side, one on the medial side. Okay? And then coming through the middle, we have crisscross ligaments. Posterior cruciate starts on the posterior, origin on the posterior, insertion on the inferior side. The anterior cruciate are inside of that, and they start on the anterior of the origin and insert to the posterior. Basically, you've got ligaments doing this to tie the knee together. Does that make sense, y'all? How to stabilize it. All right, let's move on. So here, if I was to show you a picture, by the way, of the top of the tibia and ask you what's anterior, what's posterior, posterior has the little groove and a little bit of a notch. The anterior has a little bit of a point. Everybody good with that? Yes? All right. Now, the meniscus, right here or right here, actually, right here and right there, yeah, the articular cartilage below. Those, you've heard people talk about blowing out a meniscus. We're talking tough fiber cartilage. They're pretty strong, but it's possible to have too much impact on the knee and mess that up. And obviously, if you twist the knee, that's where you break the ligaments. Anterior cruciate and posterior cruciate. Okay. Remember, we're looking at the tibia here, so this is the bottom. This is the insertion. Okay.
This is the next of each of the massive fly, anterior and posterior.
Now that's simple. All right. Joint capsule, back and sides, missing in the front. You might say, well, how can the capsule hold the synovial? You've got the bursa to hold, right? So we still have synovial fixation, subsynovial membranes, making the fluid that they're part of the bursing. All right. On the front, on the interior, the quadriceps tendon makes the three ligaments that run from the patella to the tibia. Have the patellar ligament on the front. That's an extension of the quadriceps tendon. Then you have the lateral and the patellar retinaculum. A retinaculum is like a band, doctors are tapping your patellar ligament. 12 different bursa, 12 different fluid filled cushions. So, so complicated. All right. So, look right here. See it's saying the quadriceps femoris, and it's drawing the three different things. Well, quadriceps, probably guess there are four muscles involved. This one right here, straight up the middle, that's your rectus femoris. That's the one that continues down to the patella, attaches to the patella. And once it's past the patella, we're going to call it patellar ligament. Does that make sense? All right. Anyway, the medial patellar retinaculum is here, medial side, lateral on the lateral side, straight forward. Interior crest, the work that here. So we have ligaments that are part of the capsule and ligaments that are not. What's the difference in a tendon and a ligament? Don't remember? Tendons tie muscles to bone, ligaments link bones together. That's why when we here, this is the same connective tissue coming out of the muscle going all the way down and inserting on the tibia. But when it comes from here down to this big sesamoid bone, we're still calling it a tendon because tendons tie muscle to bone. When it continues from here to here, it's coming from a bone to a bone, so we're going to name it. At that point, we're going to call it a ligament. Bones together. Everyone good? All right, so capsular ligaments, intercapsular. Capsular and extracapsular, they prevent you from hyperextending your knee. Fibular and tibial collateral ligaments, they stop you from rotating the knee, extend them. The oblique popliteal ligament stabilizes the joint. That's one that I will probably emphasize. I want you guys to know, because if you know the popliteal ligament, it'll be easy for blood vessels to remember the popliteal artery. Clear? All right. So oblique and arcuate popliteal ligaments. The oblique stabilizes the joint. The arcuate reinforces it back. All right. And again, the stuff in boldface is what we just talked about. This, you know, is the posterior. It's the back view. Because one of the things that we have here is the gastrocnemius, lateral head of the gastrocnemius. We're talking the calf muscle. So, anyway, oblique popliteal ligament, which is right there and right there. And lateral, tibial lateral there. Collateral ligament, fibular collateral ligament. This is a good one to do because of the name. You know, it goes to the fibula. You know, the fibula is the smaller of the two bones, and one of the collateral ligaments. So, yeah, I like that one. All right. The ACL. Hear a lot about the ACL for athletes. Okay. Intercapsular, these are ligaments linked muscle to bone inside the joint capsule, but outside the synovial capsule. And the ACL is the anterior cruciate, so it attaches to the anterior tibia and prevents forward sliding of the tibia, stopping hypertrophy. The posterior cruciate attaches to the posterior tibia, prevents backward sliding of the tibia, forward sliding. Hold on. Hold something. That matches that, but yeah, okay. All the pictures agreement with that text, but that means that I said the wrong thing. Like, anterior cruciate inserts on their name insertion. Is that clear? And posterior cruciate inserts on the posterior. So they are named for their insertion on the tip, not the original. Got that. Here we have the joint capsule pulled away. This is really good to see the ACL. All right, so femur, articular cartilage, medial, right? The tibia collateral ligament is on the side, which is the side. The lateral meniscus, the fibula is to the lateral. You've got your lateral meniscus. Remember, those are tough pads of fibrocartilage. All right, pelvis cut and pulled away, so we can see that. The anterior cruciate inserts on the interior of the tibia. The posterior cruciate inserts on the posterior of crisscross. They are inside of that joint capsule area. That's why they are intercapsular. And that's a question that would be really easy to do. What is an intercapsular ligament? What is an extracapsular? Does that make sense? Let's see. Yeah, we're close to the end. I know we're wanting to break. So, there's our pretty rotatable model, so you can see the whole thing. See how prominent the intestines are. They're important. All right. There is a section going down. Again, just like the front, telephone away. All right. This is what matters to y'all as your athletes. The knee has to take a lot of shock, and it has to be able to rotate. Three types of things that get messed up on the knee. The collateral ligaments, the cruciate ligaments, and the cartilages of the okay. A lateral blow to the knee, we're talking about hitting it from the side or hitting it from the side. You tear the tibial collateral ligament and damage the medial meniscus. The bone is doing this. Injuries that affect the ACL are common in runners if they change direction quickly or if they twist. And usually this is going to involve surgery. Put it back together, not something we'll throw back. The reason why is because we have to. Should everybody be clear on that? Yes? No? All right. Griffin, with me onto a board. All right. So, unhappy triad showing the three things that get messed up. Here we have a knee. getting, in this case, it's getting smacked in the side by a hockey puck, smacked on the lateral side. We can mess up the tibial collateral ligament. When we do, we're switching down. We can tear or mess up the meniscus and tear the ligament on the front. If we tear that, obviously the knee shifts like that. Tibia comes forward. Does that make sense? If we tear this, go forward and medial. All right, so common disorders in joints. Tear the cartilage. This can be because there's compression or stress. Fragments can cause joint lock or binding. In other words, if you rip your meniscus, you have little pieces of cartilage, they could get in there and prevent the articulation from working the way it's supposed to. That's the joint lock. It says here cartilage rarely repairs itself. We've talked about that before. You remember I said that bone has lots of blood coming to it? Cartilage has very little. So if you got, one of the example I used before was if you got a infection inside the joint cap or infection inside the cartilage, it's really hard to fight because you don't have the blood delivering by blood cells. You guys remember that? Well, if you get a little tear, it's hard to repair because you're not delivering nutrients, you're not delivering oxygen very much, you don't have good blood flow. Repair is done through arthroscopic surgery. If you took out a damaged meniscus, part of the damaged meniscus, the joint would be less stable, but it could at least it could at least be moved. If you had to completely remove it, then you have osteoarthritis where you have bone rubbing on bone instead of on cartilage and extreme pain. Move, but it's going to hurt. If someone's young enough, they can try transplanting a meniscus. And we're hoping in the future that you can throw the cartilage in a lab, then surgically implant it. Everybody good with that? All right. So here is a picture of a torn meniscus. Chris, if you feel a little light there, so like see there. I still don't see the tear very well. No, I meant her lights, but yeah, go ahead and try it. Go ahead and try to fill the lights.
Yeah, what do you mean?
Yeah, I still don't see the tear, unless they mean this tear right there. This roughened surface there might be the tear they're talking about. That's all I'm guessing. Anyway, if you get a tear, it's going to be hard to repair. All right, if you get a sprain, you're stressing ligaments. It's not nearly as dangerous, but you could sprain an ankle, a knee, sprain your back. These are partial tears, and they grow back slowly, again, because you don't have a lot of blood vessels coming. Not delivering a lot of nutrients, a lot of oxygen cells to grow. What can you do if you tear a ligament? Sew the ends together. You could graft in pieces of tendon from somewhere else, pieces of ligament from somewhere else. Could stabilize and immobilize the joint and hope that it'll grow back well. If you dislocate a bone, oh, by the way, when we talked about those 5 main synovial joints, which one did they say is dislocated most often? No, they actually said the jaw. Yeah? Yeah, so if you dislocate a jaw, if you dislocate bones, you have the bones out of alignment. If you dislocate bones, you have the jaw, the jaw, the bone, 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 the This is usually one of the things that happens, sprain or inflammation. Joint. This can happen from a fall. This can happen from things that happen when building sports. And got to treat this to try to save joints or like the bones like that. And like this, got to get them back together as much as possible. Reduce how far they're dislocated. And subluxation is the fancy word that we use for a partially dislocated joint. Okay? But the treatment, you get it back in place, try to avoid pressure. Okay, you know what bursa are now. You know the little fluid-filled sacs, right? You know that they cushion the movement of tendon. If you have inflammation, itis just means inflammation of. If you have inflammation of the bursa, little sacs, then you are going to have pain. This could happen if you hit the bursa. It could happen if you did something that caused lots and lots of rubbing going over the bursa. Rest, ice, maybe anti-inflammatory drugs. We hope it's not that bad. Tendonitis, again, itis, inflammation of the tendon. So actually, inflammation of the tendon is through. Again, caused by overuse. Symptoms be like bursitis. What are we talking about there? Well, a really big one would be carpal tunnel syndrome. Okay? A lot of tennis players get that. A lot of people who type get that because tendons are moving that tendon sheet. And if you're doing it all day long, you could rub it wrong, literally. Does that make sense? All right. Arthritis. There are a couple kinds of arthritis. Osteoarthritis, rheumatoid arthritis, gouty arthritis. All right. It says inflammatory or degenerative. Rheumatoid would be inflammatory. That's usually caused by your body attacking itself. Your immune system attacking your own joints trying to destroy them. Arthritis in general causes pain, stiffness, swelling. Really bad forms can be caused by bacteria. Acute, they can come on suddenly. And you can treat them with antibiotics. But rheumatoid arthritis, you're going to have to give the person something that lowers their immune system, get rid of some of the symptoms. Then they run the risk of getting sick all the time. Osteoarthritis, that's bone degeneration. Gouty, that's building up crystals. I think bonding crystals, but little jagged crystals from the amino acids they build up, and those crystals will gouge, dig at the bone to try to articulate. All right, so osteoarthritis is the most common kind. Once you get it, you've got it. You can't really do anything to reverse it. This is going to wear the joint now. You could be releasing enzymes in the body that are destroying cartilage. This happens whenever you are breaking down cartilage fast as you replace it. Bone spurs can happen. When this happens, the cartilage might get bone on bone, you're going to get bone spurs. Osteophytes with the fancy for bone spurs. That's a good one. By age 85, half of Americans have osteoarthritis, more common in women than men. The rheumatoid arthritis is probably the one that is there. No, it's going on. When we get to rheumatoid, that's the one where it's an auto or body's attacking itself. Osteoarthritis is normally part of aging. Joints get stiff. They make a crunchy noise, crepitus. especially when you're first getting up. How do you solve osteoarthritis? You left back. Take pain relievers so you can still get around. Capsaicin creams and pepper creams that you can apply directly to the joint. You can also take supplements, glucosamine, chondroitin, things like that. They don't really help. A lot of people think they do, but they don't. All right. Rheumatoid, that's a long-term condition, a chronic condition. Like I said, an autoimmune disorder, we don't know exactly why it's happening, but your system is attacking your own body, attacking your own joints. It says usually ages 40 to when the onset is, but it can happen earlier. Affects 2 times as many women as men. I know someone who has this, and sometimes. And it's exacerbated by overuse. There was a time that we were climbing a mountain on an island, and that person could not walk. I mean, getting to the top of the mountain took 4 or 5 times the normal person to walk up. And I have to say no, first the year before, and I'm not a good person, and walked up. It was a tough trail, but when I went back the next year, the person had foot arthritis. It was a slog. Anyway, signs and symptoms. Have joint pain and swelling. Usually it's on both sides. You could have anemia. Why? Well, remember, your bones, your long bones are where you're taking blood. So have those bones attacked by the system, by the destroying blood. Osteoporosis, porous bones, muscle group, the heart problem. I'll tell you right now, if someone has rheumatoid arthritis, they probably have other autoimmune disorders at the same time. It might be Sjogren's, it might be Crohn's, it might celiac. It might be lupus. But yeah, someone has rheumatoid arthritis because their immune system is attacking their body. It's not just it's going to be lots of parts of the body. All right. So rheumatoid arthritis starts with synovial membranes in the affected joints, and it could start with different points of the body. I know someone where RA started shoulders and started. The inflammatory cells, blood cells are going to migrate to inflammatory chemicals, destroy synovial fluid that causes swelling. The plane, that's where arthritis, the inflammation. The inflamed synovial membrane will thicken, makes it called a canus, the cartilage. In other words, it does the exact opposite of what we're supposed to. Remember, we're supposed to take that artery. Instead, we're hanging on to it harder. Canvas will erode the cartilage, cartilage forms, and it will make bones that are supposed to be put together. Treatment for RA. People could have anti-inflammatory drugs, steroids. You could give the person immunosuppressants. The person I know is on immunosuppressants. Sometimes give them tumor necrosis factor. I'm talking about cancer to block the inflammation. And the big thing is there's probably enough replacement, that kind of thing. There's an example of a hand formed by arthritis, both sits together and him. Anyway, imagine how uncomfortable that was. All right, gouty arthritis, uric acid. So you're depositing crystals of uric acid in the joints. This is more common in men, really common at the base of the big toe. By the way, what's the anatomy name of the big toe? Remember the big digit here, the thumb is the pollex. What do we call the big toe? But come on, it's a really testable question. Tajay, if I gave you the first letter, do you think you could do it? It's an 8. 8? Yep. What's the anatomy name for the big toe? I could totally test on that. Your thumb is your pollex. Big toe is your hallux. Well, what they said right here is that gouty arthritis can happen often at the base of the toe, right? If it's untreated, the ends of the bone fuse together and then you can't move the joint. How do you solve this? Drink plenty of water. Avoid alcohol. Avoid foods that are high in purine. That means don't eat sardines, don't eat liver, don't eat kidney. Good? Yep. Lyme disease. Tick bite? All right. If you get this, it tends to have a bullseye looking graph. A graph where it's red and then not as red, and red and not as red. That's what's going on. When you have that rash and you get like symptoms, you're going to have trouble thinking. It could make your joints hurt, your arthritis. To treat it, you're just going to have to take antibiotics for a long time. If you're someone who's outdoorsy and goes hiking and stuff, it's a lot better to hike in long jeans, long sleeve shirts, and maybe more comfortable to hike in shorts. But have long jeans and tuck them in your boots or put them around your boots, tie them off. So you can fix outside, check each other for ticks when you get back. There are other tick-borne. If you're up in Colorado, Rocky Mountain spotted tick fever, another problem. But anyway, Lyme disease. Anyway, developmental aspect points. What the hell? All right. So, the 8th week of pregnancy, the joints start to look like adult joints. Size, shape, and how much they modify the hemorrhage. Or we use a joint that's taking the capsule, and it's getting extended in one direction. Does that make sense? And the older you are, the more effective it has the points. Ligaments and tendons get shorter, get weaker. Your intervertebral discs are more likely to herniate. If you're over 75, you probably have some amount of osteoarthritis. And full range of motion exercise is the key to postponing joint problems. So exercise, but not normal exercise, stretching exercise, where you're pushing the joint as far as it can go. That lets you pushing that joint. Lock up. Does this make sense? All right, and now let's go on a break. Can you turn on the light, Chris? Thank you.